Lesson 6. Sexuality in Schizophrenia, how to understand it and how to support it as a caregiving partner. When someone living with schizophrenia is in a relationship, their partner becomes their closest caregiver, witness to change, and guide on the path to recovery. Sexuality, usually something natural, spontaneous, and based on the free flow of affection, becomes one of the areas most deeply affected by the illness and by treatment. What used to be simple can suddenly turn into a source of anxiety, shame, silence, avoidance, and sometimes pain and misunderstanding. Many couples experience these changes as a crisis in the relationship, even though in reality they are consequences of neurobiology, disturbed emotions, and medication effects, not a sign that love has died. The purpose of this lesson is to restore clarity for the partner. You are not to blame for the changes in your partner's sexuality. And they are not to blame either. Sexuality in schizophrenia is shaped by complex biological and psychological processes that need to be understood so that the person living with the illness is not burdened with false interpretations. Schizophrenia and sexuality. Schizophrenia, even before medication is introduced, causes changes that hit the capacity for intimacy. The person loses energy, withdraws into themselves, and their emotions run in an irregular, sometimes broken way. Anhedonia appears, a reduced ability to experience pleasure, and this applies not only to joy but also to arousal and tenderness. The person is not avoiding closeness because they stopped loving. They avoid it because their nervous system has become unresponsive to things that used to bring pleasure. At the same time, schizophrenia distorts self-image. The person may look in the mirror and not fully recognize themselves. Their self-confidence changes, their sense of attractiveness shifts, their connection to their own body becomes weaker. In women this can lead to withdrawal or a sense of inadequacy. In men it can lead to outbursts of frustration or, on the contrary, to indifference. Disordered thinking, anxiety, and a sense of threat further weaken libido. All of this happens independently of the relationship and must not be interpreted as emotional coldness or loss of love. In acute phases, impulsive or sexually risky behaviors can also occur, not because the person really wanted this, but because in psychosis their impulse control and judgment are seriously impaired. The person acts under the influence of delusions, voices, or emotions that at that moment are overwhelming and unquestionable. After stabilization, shame and guilt are common. For this reason, the caregiving partner must know that such behaviors are symptoms of the illness, not conscious moral decisions. How antipsychotic medication affects sexuality. Once treatment begins, even more visible changes appear, this time biological and, unfortunately, quite predictable. Antipsychotic medications lower dopamine, one of the main neurotransmitters responsible for sexual drive, motivation, and the ability to feel pleasure. Blocking dopamine receptors also leads to hyperprolactinemia, elevated prolactin levels, which suppress sexual function in all genders. In women, high prolactin can cause loss of periods, vaginal dryness, lower arousal, pain during intercourse, and difficulty reaching orgasm. Self-esteem often drops as well, especially when medications cause weight gain, which they very often do, and quickly. Facial expression can change, energy levels can fall, skin can look different. All of this adds up to the image of a person who wants to love, but whose body and emotions no longer respond the way they used to. In men, antipsychotics can lead to erectile difficulties, reduced testosterone, problems with ejaculation or lack of ejaculation altogether. The person may feel arousal in their head, but the body does not follow. For many men this is painful and humiliating, and they are ashamed to talk about it. The partner then sees only distance, silence, irritation, or withdrawal, and may misinterpret this as emotional rejection, when in reality it is simply a side effect of the medication. None of these symptoms are caused by lack of love, betrayal, emotional distance, or deliberate avoidance. They are caused by biology. That is why the caregiving partner must know about them, so they do not suffer in silence, do not create false stories in their mind, and do not burden the person with accusations that have nothing to do with reality. Sexuality in schizophrenia is a particularly sensitive area, because it changes under the influence of both the illness and the pharmacological treatment. Many reactions that a partner might interpret as rejection, emotional coldness, or lack of love arise not from feelings, but from neurobiological changes and the heavy psychological load under which the person lives. The caregiver's role is first of all to understand this process and tune into the person's needs without blaming themselves and without putting pressure on someone who is already struggling with enormous inattention. Antipsychotic medications change the body in many ways that can strongly affect self-esteem. Weight gain is one of the best-known side effects. The body holds onto fluid, metabolism slows down, fat is stored differently. The face can become less expressive, almost frozen, due to the medication's impact on the extrapyramidal system and muscle tone. Skin tone and texture may change. These changes are often very hard for the person to bear and can lead to withdrawal, shame, and the belief that they no longer deserve closeness. The partner still sees the same beloved person, but the person themselves may see someone completely different, someone they find hard to love. In those moments, the core issue is not libido or feeling, but fear of being judged. The person often avoids intimacy because they are convinced they are not suitable for it. During psychotic episodes, sexual behaviors can also appear that are completely out of character for the person, impulsive decisions, sudden interest in strangers, risky or even desperate actions. For the partner, these may be among the most painful experiences because they can look like betrayal or infidelity. It must be clearly said, someone in psychosis is not guided by free will. In that state, they do not recognize the consequences of their actions and do not understand how their choices affect others. They may act under the influence of delusions, commanding voices, or distorted beliefs about who they are. This is not a decision driven by desire or a wish for adventure. It is a symptom of a breakdown in brain functioning. When the episode passes, the person usually feels deep shame, anxiety, and confusion, and in conversation they need, first of all, a sense of safety, not accusation. Talking about sexuality under these conditions requires enormous delicacy. Instead of asking why the person avoids closeness, it is better to say that you see their body responding differently and that you want to understand their needs without imposing your own expectations. The person must know that they do not have to prove anything, not their love, not their loyalty, not their readiness for sex. Many people are so afraid of disappointing their partner that they withdraw even more. Sometimes a single reassurance that closeness is not a duty or a test of the relationship brings tremendous relief. These conversations are best held during more stable phases, when the person can manage their emotions and reflect on their experiences. During relapse or marked agitation, sexuality is one of the areas most vulnerable to distortion, and conversation about it may be experienced as pressure or threat. It is essential to remember that the person does not control their level of libido or the quality of their responses. This is biology, not choice. Any attempt to interpret their behavior in terms of trying or not trying causes deep harm. There are situations in which, despite all efforts, a couple needs outside help. If communication is breaking down, if sexual anxiety, shame, or guilt appear in the relationship, it is worth considering a joint consultation with a psychiatrist or sex therapist. This is not a sign of a weak relationship, but an act of care and maturity. The sexuality of someone living with schizophrenia does not have to disappear. It may change form, need more tenderness, need more time, but it can still exist and still offer closeness. What matters most is that it be understood, not judged. Regulating the caregiver's libido. When you are caring for a partner with schizophrenia, sexual life often becomes weaker and sometimes disappears completely for a time. This does not mean there is no love or that you are no longer attractive. It is a consequence of the illness and the medication. Your partner's libido may be blunted, and their body and emotions may run on a different rhythm. You may understand the medical reasons and still have your own biological needs. You should not ignore these needs or see them as something wrong. This section is meant to help you find safe ways to cope with a situation that is especially demanding for the caregiving partner. When a relationship is deprived of sexual closeness, a natural reaction is to express pressure or disappointment. In a healthy relationship that could be the beginning of an honest conversation, in schizophrenia it often has the opposite effect. The person, weighed down by medication, fatigue, and their own mind, simply cannot meet your expectations. Pressure, even expressed gently, triggers fear, guilt, and avoidance. Your disappointment drains their strength and lowers their self-esteem, leading to further withdrawal. That is why the fundamental rule is that the caregiver cannot look for a solution in their partner when the partner has little or no control over their libido. The path must run through self-regulation, not through demands that the person change. Buddhist techniques. In the Theravada tradition, there is a highly developed set of methods designed to help monks who live in complete sexual abstinence. These are not abstract or esoteric practices, but very practical tools for regulating sexual drive. Many of them can be usefully adapted by a caregiving partner who is in a close emotional relationship, but for whom sexual intercourse has become very difficult or impossible because of the illness. These techniques are not meant to suppress sexuality altogether. They are meant to reduce sudden impulses and allow you to regain control over body and mind in moments of strong tension. The most important practice used in monasteries is asubha, contemplation of the body's non-attractiveness. Contrary to appearances, this is not about cultivating disgust. It is about looking at the body realistically as a biological object rather than a sexual one. When desire arises, monks remind themselves that the body is made of elements that in themselves are not erotic: sweat, saliva, hair, muscle, blood, bone, tissue, metabolic processes. Instead of idealizing the other person's appearance, they break it down into its physiology. Modern psychology calls this dismantling the fantasy, taking apart the sexual stimulus into neutral components. As a caregiver, you do not have to use this technique in its full monastic form, but simply shifting your focus from an erotic image to a medical or biological view of the body can significantly reduce arousal. A second key method is Manasikara, seeing the body as a set of physiological processes. In practice, this means that when sexual tension arises, you deliberately turn your attention to muscle work, blood circulation, the activity of internal organs, natural secretions, skin bacteria, tissue fatigue, biological aging. This de-idealizes the image of the body and dampens automatic arousal, calming the mind and pulling it away from fantasy. For a caregiver, this can be particularly helpful because it weakens sudden impulses that tend to arise more easily when your partner is sexually unavailable. Another practice is Vedananupasana, observing the impulse without reacting to it. In the Satipatthana Sutta, one of the core meditation texts, this is described as noticing the arising sexual energy, naming it, and allowing it to pass instead of acting on autopilot. Monks train in this for years, but the principle is simple. Sexual desire is a wave that rises, peaks, and subsides if it is not continually fueled. Modern research confirms that a sexual impulse usually fades within a few minutes if you consciously avoid adding new stimuli. For you as a caregiver, this means you can regain control through a short pause and observation of your body, without guilt and without trying to shut down your sexuality. Another effective monastic practice is contemplation of consequences, called adinava. When desire arises, the monk intentionally recalls the confusion, difficulties, and suffering that would come from acting on that impulse. This method works outside the monastery as well, because sexual drive in emotionally tense situations can easily lead to impulsive behavior. As a caregiver, you can consciously remind yourself that your partner's long-term stability, the avoidance of stress, and the prevention of relapse matter more than a momentary physical need. This perspective does not deny sexuality, but restores proportion and makes it easier to choose calmly. One of the most physical and quickly acting Theravada techniques is transforming sexual energy into movement, called Virya. In monasteries, when a monk feels arousal rising, he immediately starts doing something vigorous, sweeping, carrying water, cleaning the grounds, going for a brisk long walk. Sexual energy and motor energy draw on the same biological activation of the sympathetic nervous system. If the body uses that energy in physical effort, the drive naturally drops. In caregiving, this method is extremely practical. A short burst of exercise, a fast walk, energetic housework, or any activity that requires effort can discharge sexual tension in a few minutes, without harming the relationship. Ultimately, all these techniques have one aim: to regain control over the body's and mind's response in a situation where you cannot rely on sexual support from your partner. Theravada practice does not teach suppression of drive, but its transformation and understanding. Modern psychology confirms the effectiveness of these methods. They are tools that are both spiritual and neurophysiological, helping reduce arousal, regulate breathing, quiet impulses, and maintain emotional balance. A caregiver who learns them gains new ways to stabilize their own sexual life without burdening the person living with schizophrenia and without pushing their own needs into the shadows. At-home techniques. Under normal circumstances, sexuality in a relationship finds its outlet in physical closeness between partners. Illness disrupts that balance. Antipsychotics dampen libido, schizophrenia changes body image, and the caregiver, despite love and dedication, is left with needs that are not being met. In this situation, practical, at-home methods are needed to release sexual tension in healthy, safe ways that do not place extra weight on the person with the illness. These strategies are not meant to replace emotional connection, but to protect the caregiver from frustration, psychological overload, irritability driven by tension, or excessive pressure placed on the partner. At-home ways of lowering libido start with regulating external stimuli, because these are often what trigger sexual tension. In practice, this means avoiding situations of excessive stimulation, such as scrolling social media feeds full of sexualized images, Instagram accounts focused on nudity, or shows and films that easily trigger erotic associations. Consciously filtering stimuli is not escapism, it is preventing automatic biological reactions. Many caregivers find that simply limiting exposure to sexual content greatly reduces sudden, hard-to-control impulses. A second effective tool is redirecting sexual energy into physical activity. Biologically, sexual arousal is a state of heightened sympathetic nervous system activation, the same system that readies the body for action. If that energy is channeled into movement, it no longer accumulates as tension. A brisk walk, climbing stairs quickly, vigorous cleaning, short home workouts, or any kind of exercise lead to a physiological release of tension. Many studies show that physical activity lowers adrenaline and related stress hormones while raising serotonin and endorphins, which naturally calm the nervous system. For a caregiver, physical tiredness is one of the most reliable ways to calm the body without deepening frustration. Another method is deliberately cooling the body, which both traditional Eastern medicine and Western physiology regard as an effective way to diminish sexual arousal. Heat dilates blood vessels, cold constricts them. A cool shower, a cold compress on the neck, alternating hot-cold showers, or simply opening the window and airing the room can quickly quiet the circulatory system. In moments of sudden impulse, cooling the body works like a physical reset, helping you regain clear thinking. A very practical and often underestimated technique is distraction through everyday tasks that require light concentration. The point is to choose activities that engage the mind enough to pull it away from escalating fantasy but are not so demanding that they create more stress. This might be cooking, folding laundry, planning the next day, gardening, writing messages, reading, or doing puzzles. In psychotherapy, this is called cognitive shifting, and research shows it is one of the most effective methods for weakening impulsive behaviors, including sexual impulses. Another important group of home strategies are breathing and nervous system regulation practices that restore balance between the sympathetic and parasympathetic systems. Exercises such as lengthening the exhale, for example, inhaling for 4 seconds and exhaling for 6 to 8, diaphragmatic breathing while lying down, gentle stretching, or short meditation sessions calm the body at a physiological level. Libido does not disappear, but its intensity drops, instead of a crashing wave, it becomes a manageable level of tension that does not disrupt daily functioning. Many people report that regular breathing practice makes sexual impulses less frequent and less intense. For some caregivers, reducing overall stress through warmth and relaxation is also helpful, because not every feeling of sexual arousal is truly sexual. Often it is a response to stress and overload. A hot bath, self-massage of tense muscles, relaxing with music, a warm pack on the neck, or light relaxation stretches can lower general bodily tension, and with it sexual tension. These techniques fit well with a therapeutic approach. You discharge tension at its source instead of focusing only on the symptom. Finally, and for many people most important, is safe masturbation, treated not as an escape but as a form of physiological regulation that prevents mounting frustration. Modern therapeutic guides are clear: masturbation is not inherently problematic. In a relationship where sex is limited or absent because of illness, it can protect the caregiver from impulsive decisions, inattention, growing resentment, and escalating feelings of unfairness toward the partner. If you use sexual aids, they should be used discreetly, in a way that does not burden the person with the illness and does not intrude on the relationship. This way of coping is fully in line with the therapeutic goal, stabilizing the caregiver's emotional state and preventing crises. Infidelity. In relationships where mental illness takes away intimacy for many months or years, a very uncomfortable yet deeply human question appears: what should you do with your own libido when sexual closeness in the relationship has almost completely disappeared? Many caregivers find themselves in a situation they never expected. They love their partner, they care about them, they look after them every day, and at the same time their own body keeps functioning according to biological laws that do not disappear just because the other person is ill. In these conditions, infidelity sadly becomes a common phenomenon. It does not arise from a lack of love, but from overload, loneliness, lack of tenderness, need for touch, and simple biology. Instead of condemning it, we need to understand it, and above all, describe its consequences honestly. Infidelity is not a neutral event. It introduces tension, secrecy, risk, and inner conflict into the caregiver's life, and over time this takes a toll both on them and on the person living with the illness. The first and most obvious danger is sexually transmitted infections. Many of them, such as HPV, syphilis, chlamydia, or gonorrhea, are initially asymptomatic, and yet they attack the body and can be passed on to a partner at home, even if the couple is not having full sexual intercourse. Contact with blood, saliva, household items, or small cuts that occur in the course of caregiving can be enough to unknowingly pass an infection further. For this reason, any sexual encounter outside the relationship requires full protection and later screening tests. Otherwise, the health of both partners, the person living with schizophrenia and the caregiver, is at risk. A second consequence, much less visible but often more destructive, is the impact of infidelity on the caregiver's psyche. Even if the partner never finds out, infidelity always changes something on the inside. It creates a double loyalty and a double life, one life full of responsibility and care, the other created out of the need for closeness. In the longer term, this split lowers empathy toward the person with the illness and subtly erodes the foundations of the relationship. The caregiver, having an emotional escape route outside the relationship, becomes less patient, gets irritated more quickly, and their inner sense of guilt slowly cuts them off from their partner. Infidelity starts to live a life of its own. It weakens attachment, undermines the bond, and every new conflict becomes bigger than it would have been before. Relationship psychology is clear on this point. Infidelity changes the dynamics of a partnership, even if it is perfectly hidden. It is also important to remember that infidelity affects the caregiver on a biological level. Secrecy consumes energy. Fear of being found out is exhausting. Being torn between duty and the need for closeness leads to chronic stress and sometimes even depression. Infidelity may bring a moment of relief to the body, but in the long run it usually increases the caregiver's emotional burden rather than lifting it. If infidelity does happen, and it happens more often than anyone wants to admit, the first priority must be to protect your own health and the health of the person you are caring for. That requires an honest look at your behavior, getting tested for sexually transmitted infections, using protection during every sexual contact outside the relationship, and avoiding risky relationships that might add even more psychological strain. If the situation starts to feel overwhelming, if the caregiver feels as though their emotions are tearing them apart from the inside, the best step is to talk to a professional, a psychologist, therapist, or sex therapist. Not to pass moral judgment, but to help understand what is going on internally and how to go on living in a way that is more aligned with your own values. Pharmacological options. When the absence of sexuality in a relationship becomes long-term, and the caregiver's tension starts to produce suffering, frustration, or the risk of destructive decisions, it is worth knowing that medicine does offer pharmacological tools that can deliberately lower sexual drive. This does not mean an encouragement to use them. They are not intended for self-medication. They cannot be safely bought on your own, and libido must never be managed with medication without a clear indication and medical supervision. But the caregiver should know that such options exist, because sometimes a conversation about pharmacological support is precisely what opens a way out of the trap of overwhelming sexual tension. Historically, the best-known agent of this type was potassium bromide, commonly called bromide. Its use is associated with the military, cadet schools, and closed institutions where it supposedly lowered libido and calmed men down. In reality, potassium bromide worked mainly through a mild sedative effect and by reducing nervous system excitability, and the drop in sexual drive was just a side effect of general slowing and dulling. Over time it was completely withdrawn from general medical use because its effect on the brain was far too broad. It is mentioned here only because caregivers often encounter the cultural myth of a pill for libido, and it is worth knowing that bromide has no place in modern treatment and should not be revived in any form. Modern medicine uses safer, better-studied drugs that can lower sexual drive, but only when there is a clear clinical reason, for example in compulsive sexual behavior, in people with extreme overexcitability, or in certain psychiatric conditions. The most common medications used in this context are selective serotonin reuptake inhibitors, SSRIs, which, in addition to their antidepressant effect, have a side effect of reducing libido, making arousal more difficult, and delaying orgasm. For many caregivers, this can be important information. If sexual tension begins to affect their life in a destructive way, a psychiatrist may consider choosing a medication with this particular side effect profile that helps maintain emotional stability and is still safe overall. In some cases, drugs that lower testosterone or affect androgen receptors are also used, but this applies only to serious sexual disorders and should never be considered without a very clear medical indication. It is helpful to know that such interventions exist, but caregivers should not see them as everyday options or ways to cope with the lack of sex in a relationship. These are clinical tools, not lifestyle solutions. For caregivers who prefer gentler approaches, there are natural and non-invasive methods that medicine and nutrition science often list as supporting a mild lowering of sexual tension without harming health. One is dietary change, increasing intake of foods rich in phytoestrogens, such as soy and flaxseed, reducing simple sugars, avoiding caffeine and alcohol, and eating more fiber and root vegetables. A diet that emphasizes complex carbohydrates and tonifying foods such as oatmeal or whole grains can gently reduce arousal and stabilize mood. These are not anti-sex foods, but they do help move the body toward a calmer, more grounded energy. Supplementing magnesium or calcium can also be helpful, because both are involved in regulating the nervous system, reducing excitability, and supporting relaxation mechanisms. They do not lower libido directly, but they decrease physiological tension that is often confused with sexual arousal. Calming herbs such as chamomile, lemon balm, or passion flower work in a similar way. They do not shut down sexual drive, but they soften the biological impulse and shift the body toward a more measured rhythm. All these methods share one trait: they are gentle, gradual, and non-invasive. Their purpose is not to turn off sexuality, but to soothe tension that can be especially painful in the demanding circumstances of caregiving. However, if the caregiver notices that their sexual needs are becoming truly overwhelming and the home strategies are not bringing relief, talking to a doctor is the only sensible next step. The point is not to punish yourself for your biology. The point is to acknowledge reality and find a solution that will let you keep fulfilling your caregiving role without constant suffering and inner conflict. Summary: caregivers often feel guilty about their own sexuality, as if they should somehow switch off their needs in the name of caring for their partner. This is a mistaken view. A caregiver who constantly suppresses frustration becomes more prone to outbursts of anger, irritability, tension, and resentment, and that directly affects the person living with schizophrenia. The caregiver's emotional balance is a cornerstone of stability for the whole relationship. Taking care of your own sexual needs is therefore not selfish, it is an act of responsibility and a part of mental health. The absence of sex in a relationship affected by schizophrenia is not the fault of either party. The person living with the illness does not control their libido, and the caregiver does not control their biological needs. What matters most is finding a way for the caregiver to function without chronic frustration and without placing responsibility on the person with schizophrenia for something they cannot change. Arousal regulation, Buddhist techniques, simple home strategies, medication, masturbation, these are tools that can genuinely help maintain balance. In more difficult situations, professionals are there to help. The key insight is this: by taking care of themselves, the caregiver is also taking care of the person they love and of the relationship as a whole.